I'm going to wait about 1 more minute for other folks to log into the Zoom, and then we'll get started. Okay, I think in the interest of everyone's time, we'll go ahead and get started. I'm Christy Giuliano, the Executive Director of the Big Cities Health Coalition. BCHC is a forum for the leaders of America's largest metropolitan health departments to exchange strategies and jointly address issues to promote and protect the health and safety of the nearly 62 million people they serve. You can see our member cities and counties on the slide there. So thanks everyone for joining us today. We'll do some quick housekeeping details. The session is being recorded. All of the lines are muted except for the speakers. You can use the raise your hand feature or chat Gabrielle Nichols in the chat if you're having any technical difficulties. And you can also use the chat feature to share questions, and we'll get to those later on in the session. So I'm really excited today to have two of our members with us. Dr. Letitia Dzirasa began as the Commissioner of Health for the City of Baltimore in March 2019. Prior to that, she was the Health Innovation Officer at Fearless Solutions, a Baltimore-based digital services firm that builds custom software solutions for government clients. She has close clinical ties to the Baltimore community as well, having trained at Johns Hopkins Hospital in pediatrics and having worked as medical director for school-based health and quality at Baltimore Medical System from 2013 to 2016. Letitia believes that equitable care is a basic right for all and is a tireless advocate for programs that support overall health and well-being. In addition to her MD, she has a bachelor degree from University of Maryland, Baltimore County in biological sciences and graduated from Meharry Medical College summa cum laude in 2017. So thanks, Letitia, for being here. And then Rita Nieves was appointed the interim director of the Boston Public Health Commission in December 2019. In this role, her portfolio includes running the health department as well as Boston EMS, substance use treatment facilities, and the largest homeless services program in New England. Among other priorities, she's committed to advancing health equity and racial justice for all Bostonians. Rita began working at the Commission in 1994, most recently serving as Director of Organizational Development at the Office of Recovery Services and assisting the office in a strategic planning process for the reorganization of the Bureau of Recovery Services and the Mayor's Office of Recovery Services. Before that, Rita was the Deputy Director, where she worked to establish priorities and manage the ongoing health equity work of the department, as well as accreditation. Rita holds an RN and an MPH from the University of Puerto Rico Medical Science Campus and an MSW from Simmons College in Boston, Massachusetts. So Rita, thank you too. So glad to have both of you with us. So Letitia, let's start with you. How would you characterize the current state of the outbreak in your city? What types of challenges are you facing every day?
Yeah, I mean, I think that honestly, in some ways, every day is different. We have seen many small outbreaks since our peak, which we actually had an initial peak in May, had significant closures. We came down in terms of our case count, reopened in June, and then saw another peak in early August. And so we closed things again, and we've subsequently seen some improvement. But right now we're experiencing a couple of small outbreaks in parts of our city, and we have a larger outbreak in the northwest part of our city. So, you know, it is waxed and waned, but it does feel like right now we're back on the upswing of additional cases.
And Rita, how about you? What are you seeing in Boston these days?
Hello, everybody. It's a pleasure joining you today in this webinar and talking about what's happening in our city. We went through the months of the surge, and then at the beginning of June and July, sort of experienced some more calmer days and lower numbers. Some days we were averaging about 30 cases, 40 cases, a positivity rate of about 1%. And since about August, we began to see a slow but steady increase in all of our metrics. All metrics we had established back at the beginning of June, we have now surpassed. Our positivity rate is up to 4.4, and our number of positive cases per day continue to rise. So, we're at a point that obviously we are concerned about the potential upward trend that may be sustained, coming up. And like everybody, trying to figure out how do we continue to enforce the rules and all the advice that we have put out there for months, and how to keep people's attention, because I think we all, one way or another, have some sort of fatigue of staying in, keeping our distance, wearing masks, and doing all the things that we ought to do to stay safe for ourselves and for our communities and families. So really trying to think outside the box, trying to find new strategies to get our message out there, to do enforcement, and to really keep driving the message that COVID is still here. It's not going to go away. We're going into, the fall and the winter. The minute we all go inside more permanently, close our windows, our doors, we're going to be in closer proximity and running into other challenges. So really, dealing with the challenges of the moment and the increase in our numbers.
So Rita, let's stay with you. So you in Boston had one of the first cases in the U.S. in early February. You all were also part of some early antibody studies in May. So take us back to the early days, and what did that look like, and what were you doing to prepare for the inevitable spike and broader community spread?
So thinking about those days, it just feels like it was another decade. It just feels so far away, so long ago. And indeed, we were one of the 5 cities that got one of the first cases. And to some extent, it was a college student that had returned from China. And we also fairly soon got that major outbreak in the Biogen conference that took place in both Boston and Cambridge, and in a large hotel in Boston. That really, when I look back, I look at those 2 situations as a great pilot test and preparation for what was coming. And with the student situation, having to very early in the first week in February think about how do you isolate a person who's positive? How do you do contact tracing? How do you in the context of something so different, this wasn't just a regular outbreak, how do you early on begin working with our State Department of Public Health and also the CDC, how to from early on strengthen those partnerships with universities in this case, because we had to deal with what had happened in a university. And so we really had an opportunity to fine tune all those key elements of work and tasks that we've had to repeat and repeat and repeat for months. And the hotel situation was also a great opportunity for us to, it was almost like a picture of what may come in the future. I remember having to have multiple conversations with the hotel folks and our communicable disease control team, and to really figure out, so how do we manage communication and messaging around this? And thinking, back then I personally was like, we're advising a hotel to close down? Oh my God, that's unheard of. What are they gonna think? And then obviously some weeks back, we're closing all hotels, right? So it really put things into perspective when you look at it, from the distance now. And so we really had a great opportunity to pilot test and really try all of our systems and tools. And really, we have a very experienced communicable disease control team that was put to work immediately. We had an opportunity to implement the infrastructure early on. So when we saw an increase in cases, we were already up and running and ready to catch what was coming our way.
Right. So Letitia, Baltimore, didn't have as many cases until later on in sort of the national outbreak experience. What were you doing during that time, while you were seeing it bubble up in other areas to prepare, and, how did that help you handle those early cases in Baltimore?
So we actually partially activated our ICS in January. So as we saw more cases occurring across the country, we kind of dusted off that old H1N1 pandemic plan, and we began to update it, with what we were learning, with what we knew. We had gone into full ICS by early March before the first cases in our city, and then the city activated its EOC shortly thereafter, and we really just tried to handle those early cases with the limited staff that we had. We also very early on began to reach out to partners at healthcare facilities, nursing homes, our local jails, detention centers, our homeless shelters, and FQHCs to just begin disseminating information, just pushing out what we knew. We started those weekly calls very, very early on, and have kept a pretty regular cadence throughout the pandemic. We also formed a public-private partnership in late March, so shortly after our first few cases were announced, with the two largest academic institutions in our city, Hopkins and University of Maryland Medical System, and Care First, one of the largest private insurers in our region. And just early on, that public-private partnership allowed us to set up different work streams that focus on some of the major components of our response, like testing, a call center, how we push out communications, and using data to really drive our decisions.
I was stuck on mute. So like many large jurisdictions across the country, Baltimore and Boston are very diverse. We're seeing everywhere really racial disparities around the impact of COVID, whether it's cases, mortality rates, and other associated outcomes. So Rita, let's go back to you. How have you approached the issue in your jurisdiction, thinking about data and testing and resources and all of the related systemic issues? How have these racial disparities affected your response?
So that's obviously a great question, and as in I would say most cities in the country, COVID is being experienced unequally by communities of color, and one of the things that we did early on, I would say towards the end of March, recognizing that we were experiencing such a lack of testing, access to testing, was we went out there. We happened to have 22 community health centers in the city, and they're located in many of the. I think there are probably 3 or 4 neighborhoods that don't have a health center, and so we reach out to them. We asked them, if they were interested in ramping up their ability to test and work, very closely with us. We were able to fund them, and I would say by the end of May, all 22 health centers have gotten the resources they needed to be able to start testing in the community and really expand our capacity to test. When we began this, I think that the data show that about 1% of the population of Boston have been tested. So and that has changed dramatically over the months. We also have been working very closely with our city government partners, so we could look at the inequities in a broader way, including working with our economic development partners, so we can look at the economic impact of the pandemic, and have participated in a number of webinars with community-based organizations, and also have done a number of webinars with residents so they can come and hear about what's going on and how they can protect themselves. We also have established a good collaboration with the ethnic media. So we do a roundtable with ethnic media. The mayor sometimes joins, and have continued to get the word out there about everything that's going on in the city and really get information out to folks. And lastly, we were fortunate that the mayor of Boston declared public health as a racism as a public health crisis, and with that came allocation of $3 million for our department to really strengthen and enhance our capacity to continue to do our racial justice, health equity work, which we've been doing for over 20 years now. So with that money, we've been able to develop strategies that include policy, education, for example, protocols, and our ability to gather data, and are putting forward a number of strategies that are going to help us do that, collect, be in a better position in the future, in the near future, to better collect data, especially around race and ethnicity, which is a major problem right now. When we get the data from the State Department of Public Health, on an average, 40% of the race ethnicity information is missing. So that's a burden on our team to go out there and try to fill the blanks. And we were able to fill it up to 90% of the times. But we were also putting forward some, implementing some regulations that will allow us to get race, ethnicity, and other health metrics information from hospitals and health centers. So we're doing a lot of work, around policy, data collection, in education, and working with the media, working with the diverse healthcare system in Boston, and really improving testing and access to care, so we really can get services to communities of color, and doing a number of other things. Recently saw a huge increase of cases in a neighborhood in East Boston, which is primarily a Latinx community. So we were able to, with a very targeted and educational campaign, we were able to bring down, that positivity rate dramatically. So that's just one of the things that we've done. And lastly, the mayor developed, created a health inequities task force that we're a member of. So it's a very diverse group of folks that look at the data and everything we do on a weekly basis, give us advice. And we're really getting input from a very diverse group of folks around how to tackle inequities.
Great, thanks. And Letitia, how about in Baltimore? How have you guys been handling these issues?
Yeah, initially, we saw that African Americans were particularly affected, and Baltimore City is a city that's about 60% African American. So we were pretty familiar with a lot of the disparities that exist for many other diseases. So it wasn't a huge surprise to us. But very soon after, I would say like in April, we began to see this really high prevalence in the Latinx community. And that really only accounts for about 5% of our city's population. And right now, where we have ethnicity data, the Latinx community makes up 15% of all of our cases. So it definitely just challenged, I think, our efforts to be, more inclusive and more focused on a smaller subset of the population, where I think typically, we were used to focusing on, how do we target the African American population in our messaging? So really early on, we identified partners who were working in the Latinx community, including Hopkins has a clinic there. We have many grassroots community-based organizations, and our mayor's office of immigrant affairs. And we focused a lot of our initial mobile testing efforts in zip codes with Latinx population that were particularly hard hit. And so we started off with, our first mobile testing site being there. We've now been able to expand that with the help of partners, some of the FQHCs that work in that community, as well as Hopkins, to offer mobile testing throughout, in our cases, the zip code is 21224, which has been particularly impacted. What we're doing now, as we continue to, focus our messaging, is how do we support flu vaccination in the Latinx community and in the African American community. So we've done a number of flu vaccine clinics already. We've already vaccinated more than 500 individuals in the Latinx community through some community-wide events, and we're looking at how we can potentially even combine our mobile testing with our flu vaccination efforts to really target the groups that have been most heavily impacted. We've also focused on being transparent about those disparities in our dashboard and outlining specifically how we're addressing it through our mobile testing and through some of our other resources. We have a Latinx work group as well, which includes those partners to really tackle some of the challenges that are unique to this community.
So you brought up flu, so let's talk about that a little bit. It is flu. It's flu season. Everybody's trying to get out as many vaccines as possible to as broad a community as possible. So Rita, let's start with you, since Letitia brought it up. So how are you going to use flu and flu vaccination also as a process through which to think about COVID vaccination, and how are they similar and different, and how are they going to help each other moving forward?
So we have started to do, we do this in the fall, obviously, and but this year started a little bit earlier to talk about the flu and get information out there and the flu vaccines that we do out there, and really driving the message that they're not the same, and that by preventing the flu, hopefully it's one less thing that you have to worry about as we go into the fall, right? And so driving down the message, that they're not the same, making that distinction for folks, and making sure that people go vaccinate and also get tested. So we're trying to combine those two messages, at the same time.
So let's talk a little bit about schools. You both have not only obviously huge elementary systems, but also a number of universities and colleges in your cities. So what does that look like? How has the planning process been going? Sort of where are you in the whole trajectory of, opening schools at all? Letitia, let's start with you.
Yeah, so the planning process has been interesting. I think, part of it was we just didn't get guidelines, very early. So I will commend our city schools who I think early in the summer, they were looking for guidance. We had the recommendations from the AAP, but really they were looking to, the state and to the CDC for additional guidance. And so our city schools really did, if the numbers supported it, want to reopen for the fall. Ultimately there was certainly a lot of pushback from the community and again, some delay in actually receiving guidelines that would be helpful. But we've tried to work with them throughout this process. There's a health advisory group that our city schools looks to that includes members of the health department, as well as Hopkins and some other community members to really help devise how we want to begin bringing students back. So they brought a very, very small number of students back initially with a plan to reevaluate right about now. So we had a meeting earlier this week to determine what next steps would be. So the students that they brought back it was really focused on kids with special needs who were really challenged to do virtual or distance learning. And then this next kind of round of bringing additional students back, which is planned for November, again, it will focus on pre-K, kindergarten, additional students with special needs, and children who have missed more than 20% of virtual or online learning. So again, I think their goal has been, we know that we can't necessarily bring everyone back at once, but how do we identify the students that are particularly challenged to learn at home and begin to start to bring them back in pods and in groups, and again, make sure that the school obviously is well equipped to support those students.
Rita, can't speak today. What about Boston?
Well, yes, you can imagine we've had a lot to do in this area, both with Boston Public Schools and universities and colleges. And, we've worked with all our city departments on sector reopening guidance and plans, but for sure, the work we've had to do with Boston Public Schools, universities and colleges have been the most intensive work we've had to do, yet. So, starting with the schools, we we're attached to HIP, to the school department, and every step of the way we've been in conversations with them about how to prepare for the new academic year. And where we landed was that they were going to do a hybrid model, where kids will go to school Monday and Tuesday. um, a cohort will go Monday and Tuesday. Everybody's off on Wednesday, because on Wednesday they would get schools ready and disinfected and all that. And then another cohort will be in Thursday and Friday. And then everybody, whoever is not in school is studying remotely and working remotely. And that seemed to be the best option at this point. We also landed on having a phasing system, and it started with the high need students, and it was going to be followed by kindergarten, and then elementary school, middle school, and high school. Every 2 weeks, a new set of grades was supposed to be integrated. So we started school about probably 3 weeks ago, and it coincides with the high need students, which is about 1,300 students at any given day. And this is a system with 55,000 people in it. So you can put into context 125 schools, buildings. So the initiation of school coincided with the fact that our positivity rate was steadily increasing, and getting to the point of 4%, which is the metric we established to say that at 4% we would move to remotely, 100% remote schooling. But since we had started the high needs students with the tiny amount of folks, as I explained, and as you can imagine, these buildings are empty with just a handful of folks. We concurred that it was okay for them to keep the high need students, the last week and this week, and we'll continue to watch our positivity rate. And everything else got pushed down. All the timeline to bring kindergarten and the other folks have been pushed down a couple of weeks. Again, while we watch the numbers, and if we hit 5%, obviously that's going to trigger a different response to fully remote, education. So we've done a lot of protocols reviewing with our partners at public schools. Our environmental health experts have gone into schools, given advice as to what needed to be changed and prepared so the classrooms could be ready to hold classes there. And we've done some training also with staff and nurses as well. So that's just going to be interesting going forward, because at some point we'll be in the position of bringing more folks in the buildings, and we can expect and predict that we'll have some cases and we'll have some issues to continue to resolve and help our partners be able to operate. With universities and schools, which are many, as you know, again, our team have worked countless hours and really looking at, each university and college was asked to submit a plan on how they intended to bring students back, and protocols, training, testing, contact tracing, the whole thing. So our team reviewed each one of the plans with each university, met with each one of those teams to give advice and approve them. And once that happened, universities and colleges that were bringing in-person education were able to open. The communication, it's ongoing, because obviously, they've done a lot of testing. They found, cases, as you can imagine. So we continue to advise them on how to operate safely. And we suspect that that's just going to be ongoing until a vaccine, it's available and everybody can be together more safely. Some universities may not bring students back after, Thanksgiving or even after the spring. So we'll see. People are also watching and making, tweaking their original plans as needed. But those are, we've been fortunate that we've been able to have that type of collaboration with our partners, and we've done interesting things like our inspectional services department work with the universities to identify and allow some hotels to be used as places where students can go instead of a dorm. And by doing that, they were able to deconcentrate some of the dorms and create more separation, among the students. So more to come on that, but so far, we're doing as best as anybody would expect, given that, we've got a lot of folks in the city, influx of students, but also a lot of testing and a lot of, monitoring as well.
So it sounds like both of you have been able to avoid a lot of the huge college outbreaks that we're seeing in other parts of the country, which is a good thing. So, we've heard a lot in the media about the mental health of the frontline workforce, and a lot of that has focused on, doctors and nurses in hospitals. I know, so many of the folks on this webinar know that there are also real implications for governmental public health staff that have been working 24/7 since January and February. So what are you all doing to think about that side with your staff and, looking out for their mental health, and making sure that everybody's sort of able to continue to operate through this marathon, that we now all know is not really a sprint. Letitia, what have you guys been doing in Baltimore?
Yeah, I think we tried to create a space to talk about how people feel. We early on, and early on, I would say, I guess in the summer, we tried to create a time off like rotation schedule, where we like literally had everyone on a spreadsheet, and folks, had to indicate when they were going to be off so we could ensure that there was some level of coverage. And I tried to set the example by taking time off, myself. But, I think what's tough is, our bench is so shallow. When folks take off, the parts of the response are either significantly delayed or diminished, and then that person returns to double or triple the work. And so people almost don't want to take off, right? Because they know what they're coming back to. That said, I still very much encourage it. I try to very much encourage the importance of self-care in general. None of us can run on empty. At least not for as long as we think we can. And so we've tried to just create a space for people to say, you're tired, or for, the manager to say to an employee, take the time off. You need to take time off, and we'll figure it out. And again, I think that a lot of times starts with me and how I support, my immediate team. We've had some kind of virtual happy hours, again, an opportunity kind of outside of work to interact with folks and just check in and see how people are doing. And we are hoping to plan some form of a virtual all staff. We had actually just had a great all staff in January. So we're hoping to do something like that again, just to allow people to connect and do some level of recharging.
And Rita, what about in Boston? What have you guys done?
So our workforce is quite large. It's almost 1,200 folks, and about two-thirds of those have been working nonstop since the beginning of the pandemic, because it includes our emergency medical services. We run the largest homeless shelter in New England, and then our recovery services team. It's also, in the front lines and have been for months now. So it's been quite challenging, obviously, because, they're obviously by now, quite fatigued. Over the summer, one of the things, that we did was really encourage people to take time off. We all did. I took time off the minute our numbers went down, took a couple of days off to try to recharge the battery. And so we've done a lot of that. We've also done ramped up our wellness activities and have done some stuff online, and some wellness activity and virtual, games and stuff. And we've been doing for months now a survey of staff, trying to monitor how they're doing. And we started with doing it actually with the 1/3 of our folks that are in teleworking, and then expanded to everybody. And as you can imagine, the people who are doing direct care are working very long hours and more stressed out than those that are at work at home. And but even the people who are teleworking have expressed feeling a lot of feeling of isolation, disconnection, the stress of being home and having to be at home and with everything else that's happening at home, especially when all the kids were home. It's not easy at all. So we've also uh, continue to find ways to affirm that people, just because somebody's home, that doesn't mean they're doing less or are less stressed out. So we're doing that. And early on, we were fortunate to be able to provide housing in hotels to some of our direct care workers, especially EMS and the recovery and the homeless shelters staff, where for those folks that were particularly concerned about their household situation and not wanting to go home and expose, somebody who is vulnerable. So they were able to apply for going to housing, and we were able to find some dorms, and some of our universities gave us for free the opportunity to do that. So that was quite helpful to folks, because we helped them relieve some of their anxiety they were having. One of the things that I think was quite helpful and appreciated, and it took us literally like 4 months to get it done, was we're able to get approved a bonus pay for all the folks that worked throughout the surge from like March 15 to the end of May. And we were able to give $1,200 to, we had obviously a criteria that we applied. And, so up to $1,200 to each person who was providing direct care during the surge months. And lastly, the last thing we're trying to tackle that it's quite challenging, but we are committed to figure it out, is the issue of addressing childcare issues and caregivers issues. Many of our staff have, small children or school children and have all kinds of needs around after school hours of support that they need. They also have caregiver responsibilities, with older adults and stuff. So we are trying to figure out what can we do to provide some sort of support for staff in that situation. We sent out a survey around childcare needs, and we put together a committee that's looking at making some recommendations and see, how far we can get with offering some support, because that's really getting in the way of some folks being able to come to work long term. So that's our latest challenge. We try to
So ironically, my 7-year-old is doing her online PE on the other side of this wall, and so the whole room is like vibrating. So the struggle is real, even for those of us who are privileged enough to be in our houses. So we have a question about PPE and whether or not you all have had challenges getting N95s. And have you been reusing them?
I think early on there were some challenges. Our state stockpile seems like it's improved significantly. So at one point, early on again, lots of challenges, and then it seemed like in the summer after we had kind of parsed out things, that we got some big influx of a shipment. So we're in a much better position. So not reusing them. I think what's still sometimes challenging is just getting the right sizes. So I think sometimes we'll also get, a slew of smalls, but we'll be in need of larges. But we're actually doing okay right now.
Same with us, early on, some challenges around, being able to actually procure some of the, gowns always came to mind, they were quite challenging to get. And, but then, that issue went away. Our mayor has been extremely supportive and helpful in making sure that our procurement department at City Hall went out there and got, as many, items as everybody, especially those folks in the front lines, would need. And so we feel confident that we're in a good situation right now. We did try reusing, the mask and send them out to a company who was doing that for us. But I don't think we've done it in a long time. We did it when we were trying to be extremely careful with the supplies we had.
So as I introduced you both, you both have come to run public health departments through very different paths. So, thinking about how your varied careers and sort of the adjacent fields that you've worked in, how has that prepared you for, this moment and this response? And what advice would you give to young public health professionals, how to prepare for the unprecedented? I think we all need a new word because we're using unprecedented too much. But what advice would you each have sort of based on, your path here?
Yeah, that's a really good question. I think, so a few things. I'm a pediatrician by training, and I worked in private practice. I also worked in community health and school-based health before coming to the health department. So I think disease prevention is kind of naturally how I'm bent, whether it's chronic or acute diseases. So I think a lot of my approach to COVID has been through that lens, like how do we kind of promote disease prevention, whether it's through harm reduction principles, and how do we message that effectively, right? Like I think a good pediatrician learns how to message to both the parent and the child. I think likewise, at one point I had an interest in doing peds emergency medicine. So I love that there was some level of unpredictability and you got to use multiple different skill sets on any given day. And I think that is very much the case with COVID. Sometimes that skill set is navigating the politics of COVID at the local, state, and federal level. And sometimes it's, managing, staff expectations and it really depends, again, totally on the day. I think I've also been told by many, even before this role, that I have a calming presence. And I think that's helped, through what feels like a chaotic time for most people. I think, people are afraid of uncertainty. I think naturally as a pediatrician, when I would work with parents, I would always aim to be very transparent. I don't know everything, right? I don't know when your child is going to begin to gain weight like you want them to gain weight. But what I do know is here are some of the things that we can do to help you. And I will continue to follow up with you and always be transparent and honest with you about, what might happen. Again, that honesty and that transparency, I think, very much being the key to how you approach, how you're messaging and working with people in the community as we all respond.
Yeah, I think one of the really important messages for those of you who have sort of had the opportunity to message in such a way, and then, challenges with this response in particular is being okay with saying we don't yet know, or the science has changed.
Yep.
And I think we're in this unfortunate place where many in the public are interpreting it as, oh, the science was wrong. Right. No, the science wasn't wrong. We just didn't know it yet. No. So I think that will be, a huge lesson learned for the field and thinking moving forward, really being okay with that level of uncertainty and communicating that. Yeah. Rita, what's your advice to up and comers?
So I think, people ask me that all the time, and that's my training, and that's how I started in the healthcare field. And then I was really interested in going beyond working with individuals and working with populations and communities and families. And that's how I that was my initiation in public health. So when I look back, I never said, this is what I want to be doing in 5 years, or this is the direction I want to go. I only knew that I was in the right place, that, by going to school, getting my master's in public health, and beginning to work in a city health department. Back then in communicable disease control, that was my initiation. It just felt like I was in the right place. And, I was open to challenges and opportunities. I think if I would have, I mean, we can be afraid of challenges and new opportunities and increased roles and responsibilities, but we need to know when to set that aside and say, okay, so what is it that I need to be able to take this on? And if I've been afraid in different moments, in different intersections that I've been, of doing this, doing that. My first public health director job, I couldn't sleep for like 2 days in a row because I kept thinking, it was tuberculosis, and I kept thinking there was going to be a major outbreak, and I didn't know how to handle it. So, and then those 2 days went by, and then I said, okay, I got the job. Let me just figure out what is it that I need to be able to do it. And I have to repeat that throughout my career, again, because, I didn't say, oh, I want that job, or I want to do it. Just opportunities came up, and that's how I approached it. So, concentrate on what is it that you need to do. What's the next thing that you can do or is in front of you, and really try to understand how systems work. And I use the word system to define in whether it's an individual or it's an agency or a team, because if we do, then it's easier for us to figure out strategies to get the work done, and to communicate, and to collaborate, and to partner. And that's kind of like my approach to most of the things I've done. And then make sure you're passionate about what you're doing. Public health gives us the opportunity to go into many directions in many public health areas, and I think that's fabulous. And that's great, because like, I did recovery services for 20 years, and I did communicable diseases for like 4, and now I'm doing other stuff, and it's all making me a more rounded professional, just by having the opportunity to have been, in those roles. So define what you like and what makes you happy and passionate, and go get it and go do it.
I think the only thing I would add to that, and I think Rita said it beautifully, right? As you get these opportunities, really explore a lot of things within that one opportunity. When I worked at an FQHC, there were a lot of different committees, and I was still earlier on in my career. And so I was able to sit on the policy committee to understand how, an SOP was put together. I was able to do school-based health, all of these things which now are a part of my role. I had the experience, early on to kind of learn, because I was interested in, it was an FQHC. So anything you wanted to do, you got to do because they needed people to do it.
Okay, so as we start to wrap up, I have sort of 2 questions for each of you to close with. I have to give the hat tip to Gabby, my colleague, on the second part of this question. We've started ending all the webinars with this. So the first part is, what's been your most important lesson sort of over the past 6+ months? And then looking ahead, what gives you hope?
That's a good question. Most important lesson, and maybe this is a simple one that I kind of knew, but I think it's give yourself and others grace. None of us have lived through a pandemic. Most of us, let me say the majority of us have not lived through a pandemic. I think we're all learning, and we're all growing. So I think stay humble and give yourself some grace that, this is not typical times. And so you're not necessarily going to be able to do all of the typical things you might be able to do. And I think just the same, give other people grace, right? You never know what they may be experiencing in the midst of dealing with the pandemic and home life and everything else. What gives me hope? I think, you know, honestly, I can't commend my colleagues enough. I've been so inspired by how hard everyone has worked. Having not worked in government prior to coming into this role, you hear so many stories about, you know, people not working hard at city government, or, you know, all of the things that you hear, and it's just not true. And I think that gives me hope that people are still so committed and so dedicated this far in, as tired as they are, as poor as their morale is.
So, I mean, I know this, but it's been a great reminder that we need to appreciate the skills that everybody brings to the table, and especially in the context of a pandemic, where people are working long hours and are stressed out, are concerned, are, you know, fearful of what's going on in the world and outside our doors and windows. Um, we need to appreciate that we all think differently. We have different styles of working and approaching the work, but at the end, if we're at the table and we're respecting each other, you know, we get to solutions and we get to the other side. Um, and you know, similar to Letitia, you know, what gives me hope is that um, even though sometimes, especially the media, in the media, we hear things that sound negative and contradictory about what's going on, where we're going. I think that we're fortunate that both at the federal and state and city levels, we have seasoned and experienced um, public health heroes and professionals that go to work every day trying to get us the information we need and trying to impact policy the right way and get the right message out there, and working behind, you know, the scene, and that we can count that there are people like that at all levels of our systems and government. And you know, shout out to local board of health. You know, that's where the work happens, and it doesn't get more on the ground than that. And that whether it's a town that has one nurse, you know, one public health nurse and one community health worker, or 500. Um, these folks are the ones who make things work and keep us safe and are doing the contact tracing and supporting people who are infected and really connecting people to services. And when you add all that up, that's, you know, how we've been able to um, be where we're at right now and not be in a worse shape. So shout out to local boards of health, because that's where things really happen every day, every 5 minutes.
Well, thank you. This has been a great discussion. You know, and kudos to you both too for the, you know, the leadership that you have had to, I mean, have shown and have had to show, you know, to lead your departments through this response and to continue the response. So this was our 9th webinar this year in our series of talking to various big city health commissioners. Our last scheduled webinar of the year is 2 weeks from today on November 4th, with the leaders from the Houston, Texas Health Department and San Diego, California. So please join us. Also happens to be the day after the election, so we'll have some extra interesting maybe stuff to talk about if we know how that all ends up at that point. So you can find, in addition to registering for, again, the webinar in 2 weeks, you can also find recordings of previous sessions on our website. And the best way to hear about all this exciting stuff is to sign up for a newsletter, so that, you know, we are hoping to do some additional webinars in the new year. So please do sign up and follow what we're doing. So thank you again, Rita, Letitia. Thank you to everybody who listened in, and have an excellent afternoon.
Thank you.
Thanks.